Good morning. I'd like to thank the organizers for hosting such a wonderful educational activity and for the opportunity to present at this meeting. Retinitis pigmentosa is the most common form of inherited retinal dystrophy and is characterized by early night blindness, progressive visual field constriction, as well as characteristic fundus abnormalities such as these bony spicule pigmentation. Patients with retinitis pigmentosa do not lose vision immediately. There's a slow rate of visual deterioration, and visual acuity can be stable until the late stages of the disease. There are several potential structural measures for retinitis pigmentosa, and we'll discuss some of these. First, the retinal structural parameters. As you can see, there's a wide range of phenotypic findings in retinitis pigmentosa. Like with this OCT, the retina looks generally normal, as is the choroid, and this patient had good visual acuity. But in some eyes, there's actually potential for cystoid macular edema with diminution of visual acuity. You can also see here the encroachment of the bony spicules into the macular area. In the late stages of the disease, it's typical to find retinal thinning as well as choroidal thinning. And this is usually accompanied by poor visual acuity. And it's not uncommon to find these retinal cysts present in the eyes with retinitis pigmentosa. So just like a candle that's burning and getting shorter all the time, it's been well established that in retinitis pigmentosa that as the disease progresses, the retina also becomes thinner. And the group of Professor Berzon estimated that you lose 1 letter of vision for every 10 micrometers of retinal thinning. But this analysis is not so straightforward. If you look at this graph plotting visual acuity versus retinal thickness, you can see that as the retina gets thin, as it gets atrophic, there's a decrease in visual acuity. But also when the retina gets thick, such as with the onset of retinal edema, the visual acuity also decreases. We can also examine horizontal measures of retinal structure. So we can look at the outer segment area, and as the disease progresses, you can see thinning of this area, and this is usually associated with a loss of visual acuity and visual field loss. So here's a patient with a wide ellipsoid zone, but as the disease progresses, you can see shortening of that ellipsoid zone in patients with retinitis pigmentosa. And it's been demonstrated that visual loss and visual field loss is associated with decline in the ellipsoid zone as well as with RPE thickness. How about the choroid? Well, the evidence for choroidal changes in retinitis pigmentosa is somewhat conflicted. 2 papers by the group of Dr. Aiton and Dut involving 63 patients reported that compared to age-matched controls, in patients with retinitis pigmentosa, there's actually a thinning of the choroid. But the group of Dr. J. Chablani involving 69 patients showed that there was actually no correlation between retinitis pigmentosa and choroidal thickness. So why is it important for us to have structural measurements in retinitis pigmentosa? First of all, we can't rely on vision to determine whether the patient's disease is progressing because the rate of visual decline is actually quite slow. And visual field testing is prone to patient errors. Patients have difficulty because they have poor fixation. So there's a need for objective measures of retinal health, such as biomarkers for prognostication and for monitoring treatment response. I think it's a fortunate time for patients suffering retinitis pigmentosa because recently the gene therapy has been approved by FDA, and this is a step towards eventually finding a cure for patients with retinitis pigmentosa. But this gene therapy comes at a great cost, and there may be a need to identify structural biomarkers to help us choose which patients will benefit the most from these expensive treatments. So we wanted to examine what is the structural relationship with the functional parameters in patients with retinitis pigmentosa. We included patients with RP who are adults with measurable visual acuity we excluded patients with cystoid macular edema and long axial lengths. For functional parameters, we look at the best corrected visual acuity as well as the mean deviation generated by automated perimetry. We use the Triton to perform 9x9 macular scans, radial scans, and this generated some structural measures, the central retinal thickness, the subfoveal choroidal thickness, and the ratio between the retinal thickness and the subfoveal choroidal thickness. Then we looked at the linear association of structure versus function. So in our series, the average age was 45. The mean visual acuity was about 20/40. You can see that there's a thinning of the central retinal thickness in this population of RP patients, and there's a wide range of subfoveal choroidal thickness. There's also a relatively significant decrease in their visual field loss. So if you look at these pictures, this is a patient, 38-year-old. She had very good visual acuity. The retina was fairly normal. There was a subfoveal choroidal thickness of 178, and the ratio of this was 1.46. So this was associated with good visual acuity. Here's another patient with more advanced RP. You can see pigments going into the macular area. You can see a thin retina, a thin choroid, but the patient had a good visual acuity with a retina to choroidal ratio of 0.91. This is a 59-year-old male, one eye, had a moderate loss of visual acuity. The retina was thin. The choroid was also somewhat thin, and the ratio was 0.72. And the other eye of the same patient had markedly severe visual loss. The retina was also thinner, but interestingly, the choroid in this other eye was actually thicker, and the ratio was 0.27. So the visual acuity in our small series of patients was positively correlated to central retinal thickness and, interestingly, negatively correlated with subfoveal choroidal thickness. There was also a moderate positive correlation with the ratio of retinal thickness to choroidal thickness. In terms of visual field loss, there was a positive correlation with central retinal thickness, no correlation with subfoveal choroidal thickness, and a moderate correlation with the ratio of retina to choroidal thickness. So the visual acuity, as we've shown in this small series, was positively correlated with retinal thickness, and this is logical because the retinal thickness will depend on the volume of photoreceptors, ganglion cells, and other supportive cells, and as these cells die off in RP, then the retinal thickness would decrease. The visual acuity was inversely correlated with subfoveal choroidal thickness, and we're not sure as to the reason for this, but we believe that in RP, the retinal atrophy as well as visual loss is progressing more quickly than a decrease in choroidal thickness. In terms of visual field sensitivity, this was positively correlated with retinal thickness as well as the ratio of retina to choroid. It was not related to choroidal thickness, and this might be because the visual field loss is more related to photoreceptor atrophy and ellipsoid zone shrinking with accompanying retinal thinning, and the choroidal loss was not directly related to photoreceptor loss. So the limitations of this study, it's a small study. We don't have age-matched controls. It's a cross-sectional study, and we're presently doing longitudinal studies to help establish retinal and subfoveal choroidal thickness as biomarkers for retinitis pigmentosa progression. We also did only thickness measures. So in summary, retinal and choroidal structures seem to be related to visual function among eyes with retinitis pigmentosa, and measures of retinal and subfoveal choroidal thickness may be potential markers for prognostication, for patient selection, as well as monitoring treatment response. Thank you very much for your attention.